Hello everyone, I'm Namita Thapar, Executive Director of MCure Pharmaceuticals, and today we're going to talk about a very important mental condition, bipolar disorder. The prevalence is as high as 0.6%.
The average duration before which a patient will eventually get the correct diagnosis of bipolar is approximately 8 to 10 years.
8 to 10.
We are not looking at anything called mental. Everything is physical.
Isn't it better to do things like better lifestyle or meditation to not be addicted to these medicines for life?
Biggest challenge we have is from within the medical community sometimes.
So what about the side effects of a lot of these medicines?
Well, so I'm not saying no.
About 25 to 50% of all patients with bipolar disorder will attempt suicide.
Patients often say, how long? I say, how long do you want to live? Accordingly, we'll give you long treatment.
Substance abuse can also be a form of self-treatment for many patients who have episodes.
In the hands of a nuclear scientist, nuclear power is safe. In the hands of an educated psychiatrist, medicines are safe.
And to explain this and all its nuances, we have two lovely doctors with us today. We have Dr. Ashutosh and we have Dr. Rashmin. So why don't we start with you, Dr. Rashmin? Let's talk about what exactly does bipolar disorder mean?
Thank you, Namita, for having us on the show. Bipolar disorder is one of the most misunderstood illnesses, for the want of a better word, primarily because it's missed more often than it is diagnosed. You'll be surprised, the average duration before which a patient will eventually get the correct diagnosis of bipolar is approximately 8 to 10 years.
8 to 10?
Yes. So very often they'll end up getting diagnosed with anxiety, with depression. They get treated for these disorders, and unfortunately they find out the hard way when they start having other episodes as well. In the old days, we used to describe it as manic depressive psychosis. So essentially, it's exactly what the term says, bipolar. It's two different poles. At one end of the pole, you have episodes of mania, where you have a person who is excitable, who is grandiose, who thinks he is the king of the world, who is extremely agitated, restless, hyperactive. He or she overestimates their ability to be able to function. They have decreased need for sleep. They are extremely agitated with the smallest of things. They get ticked off very easily. And they go on, and these episodes may last for anywhere between 2 months to 6 months. And then at the other end of the spectrum, we have depression, right? So depression, I'm sure as most people would know, you have sadness of mood, you have withdrawn behavior, you have decreased interest in your day-to-day activities, you have anything that gave you pleasure earlier seems completely meaningless now. When the illness exceeds a certain amount of intensity, you may have ideas of helplessness, hopelessness, you may have worthlessness, you may have suicidal ideas, and you may have lack of sleep, lack of appetite. All of these eventually lead to a significant degree of compromise in your day-to-day functioning. So the patients with bipolar disorder would very often vacillate between episodes of mania and depression. But unfortunately, depression is far better understood these days compared to mania. So very often patients with bipolar may get treated and get picked on for the episodes of depression. But the manic episodes, unless they are extremely disruptive, they are invariably missed. So they'll end up getting treated for depression without the awareness of the treating physician that if you treat the patient for depressive symptoms with antidepressants and the patient has an underlying vulnerability for bipolar, you might actually lead to that kind of a switch from depression to mania because of the treatment itself. So it's a tricky thing, and it has to be understood well, it has to be diagnosed correctly, and it has to be treated differently. It is not the way it works for unipolar depression. By unipolar, unipolar depression is different from bipolar depression. So depression occurs in bipolar disorder, but it also occurs as an independent entity. Though they are both labeled as depression, they are completely different animals altogether.
So why is there this misdiagnosis? Because a lot of times people think it's moodiness or depression. I mean, what is the one thing that a doctor should know or the individual should know that this is not normal depression and moodiness? This is something that's way bigger and should be termed as bipolar. What is that one thing?
So for you to have a diagnosis of bipolar, you need to have one episode of either mania or hypomania, right? Mania I described to you. Hypomania is a similar kind of a presentation as mania is, but to a lesser extent, where the degree of compromise in your day-to-day functioning may not be as severe as it might be in a manic patient. A manic patient is going about buying things off the streets, giving things away, disruptive, aggressive, picking up fights. A hypomanic person is just generally a little more active, a little more productive even sometimes. So they enjoy that state. But that's the reason why it is severely underreported, because people feel he has been low for the longest time. So ye to achhi baat hai. We
ठीक
want
हो
him
गया
to be
है.
active.
He's fine.
Yes, so it is misunderstood as
Understood.
a pseudo improvement, whereas actually if you were to go to a qualified psychiatrist, then he may be able to pick up the nuances between what is normal and what is slightly above normal versus what is extremely above normal.
Understood. Dr. Ashutosh, over to you. What are the symptoms or signs that you look for when somebody comes to you to say whether this is depression or whether this is bipolar?
The explanation given by Dr. Rashmin is pretty clear. These are poles apart. So, manic phase, the person would be having an exalted or elated mood or an irritable mood, accompanied by a reduced need for sleep, indiscretions in spending, in also business plans, or even in sexual relationships. Plus, they do not have a risk-making ability. So they underestimate the risk and they overestimate their ability. And this causes distress not only to them, also their family members. And there are episodes which have actually bankrupted families in this. So now coming to depression, I did hear you ask that what would be the reason why people have a time lag of 10 years. So often people start off with depressive episodes. The manic episodes may come many years down the line, but there are certain, I would say, red flags. If a person is coming to you with depression, A, a strong family history of depression. B, a early onset and a severe intensity of depression. C, depression accompanied by psychomotor retardation. That means a lot of lethargy as well as sleeping more. Usually people complain of less sleep, but if they're complaining of excessive sleep and a distinct quality of mood, what we call anhedonia, that means no amount of joy is experienced even when there is some pleasurable event. These are the things which we could look and think, okay, this may be jolly well be a presentation of a bipolar depression rather than unipolar. Having said so, it will still justify treatment with just an antidepressant at that state, but we'll have a watchful eye for evolution into manic and hypomanic. Now, hypomanic, if you encounter this personality in a party, you will see this person is very charismatic. All the time people are around them, they are feeling happy. So essentially, how do you distinguish a pathology from a normal condition? In fact, I will go one step ahead to say that most of so-called psychiatric disorders are the Trojan horses of medicine. So people do not even realize that these are illnesses. And jolly well, these are systemic illnesses which are affecting the whole body, but predominantly manifesting in the central nervous system, the CNS. So
Right.
this is what I will, for now, like to inform you about, Namita.
Absolutely, absolutely. Dr. Rashmin, over to you. We also spoke about having a lot of comorbidities, right? Mental conditions by default have that. So does that happen a lot with bipolar as well?
Of course it does. In fact, comorbidities are by and large the rule rather than the exception. You have comorbidities of different kinds. You have other psychiatric illnesses, the most common ones being substance abuse. Substance abuse is extremely common in patients with bipolar disorder. It's ironically a chicken and egg kind of a situation where substance abuse may trigger episodes of bipolarity, as opposed to which substance abuse can also be a form of self-treatment for many patients who have episodes.
Got it.
So they consume substances as a means of calming themselves down or medicating themselves in a pseudo manner. So alcohol is commonly abused, cannabis is commonly abused, smoking is of course a very common thing. And very often you have patients who otherwise were non-substance abusers suddenly turn around to substance abuse during their episode. So that is very often a red flag which should alert us to the possibility that this is episodic in nature. It is not how the person was.
Right.
Apart from the psychiatric comorbidities, you also have other comorbidities. For example, patients with bipolar disorder are 5 times as likely to have cardiovascular diseases.
It's a big one.
They are more vulnerable to have heart attacks. They are more vulnerable to have cerebrovascular events. So they are more likely to have strokes. They have compromised immunity as a part of their condition. So that makes them prone to having other immunological disorders. And COPD is again very common. the chronic obstructive pulmonary diseases.
Right.
So all of these are far more common in patients with bipolar disorder as opposed to the average population.
We spoke about suicide.
That's one of the biggest challenges that we see with bipolar. Patients with bipolar disorder are 5 to 10 times more likely to have suicidal ideas and suicidal attempts compared to unipolar depression. In general, about 25 to 50% of all patients with bipolar disorder will attempt suicide. That means almost 1/3 to half of all of them.
Right.
And about 15% of them will successfully commit suicide.
Very big numbers.
A ballpark figure is a patient with bipolar is 25 times more likely to attempt or successfully commit suicide compared to the general population. So that's a huge number. And if you look at the incidence, right? So if you're talking about, say, 0.6% of the population having bipolar, say we are a country of 1.4 billion. So we're talking about 1 crore people in India having bipolar disorder diagnosed. And these figures are extremely low because they are underreported more often than not. So that means that 15% of all these people will successfully commit suicide as a part of their bipolarity. So you're talking about 15 lakh deaths.
Very large numbers.
Okay, those are large numbers. And these are very serious situations, and we need to be very diligent about picking them up at the right time and addressing them rightly. But unfortunately, until a few years back, suicide was also criminalized. So it's only in the recent past that suicide has been decriminalized. It is not a part of the legal system anymore.
Right.
And that's the reason why the underreporting of suicide was always, always talked about as an accidental poisoning, etc., etc. Now we are beginning to see people coming up and talking about it and getting it addressed, because earlier the law also was a deterrent for them to address their suicide.
Absolutely. That's very well said. Dr. Ashutosh, I want to ask you specifically about something we discussed when we were informally chatting, which is you said we should stop calling this a mental condition and call it a physical condition. And what is the reason you feel we should do that? So I think it's important not just for bipolar, but for all mental conditions to understand why it's actually a physical condition.
So first of all, thank you for remembering this and asking this. And both Dr. Rashmin and I are very passionate about this.
Yeah.
See, so-called mental disorders, there's nothing mental. There is no mind also for that matter. It's a concept borrowed from philosophy.
Yeah.
As medical students, we know that we are looking at the brain and disorders of the brain. Now, all psychiatric disorders are essentially complex genetic disorders and not just single gene, they are polygenic. So no single gene can be isolated. Now, funny part is a lot of this genetics is shared across different disorders. So the same genetic risk which codes for bipolar may also be coding for diabetes. And there's a very high heritability. So up to 85%, that means 85% causation is coming from the genetic vulnerability. And you'll have a strong family history of either bipolar disorders or diabetes or heart problems. Now, what happens is the organ responsible for our survival is our brain. You can think of it as being the CEO of our body. Imagine a company where the CEO is going bonkers. The company cannot survive for long. Unfortunately, in the society, whenever you say mental, people are like on the back step. We don't want to discuss this. We don't want to know about it. But if you say this is an illness of the brain, which has a genetic component which may vary, and it actually reduces the lifespan. I'm not talking of quality of life. Everybody knows quality of life is reduced. But the lifespan, depending on whichever disorder, is reduced between 7 to 30 years. Now, when we start looking at it at this way, we suddenly realize that in India, the average lifespan today stands at around 67 years. But this does not apply to people with psychiatric disorders. At the time of independence, the average lifespan was 37 years. And today, if we look at, say, schizophrenia, it hasn't changed for them. They live 30 years less as compared to the general population. Same thing applies for bipolar mood disorders. Dr. Rashmin already touched upon the comorbidities. There is something known as a concept of somatoprogression. That means they present with bipolar mood disorders, and over the years, due to a lot of complex biochemical changes, they become vulnerable to different physical illnesses, be it diabetes, be it blood pressure, be it cancers, heart problems, obesity, etc., etc. Their lifespan actually reduces, and they develop a lot of other physical illnesses. And not only do these physical illnesses themselves have a set of issues, they also worsen the course of bipolar disorder. So there is this concept of somatoprogression, and eventually they become vulnerable to dementias.
Right.
So
That's what it can eventually lead to.
so where over here is the mental, everything is physical. The presentation may be mental, that means subjectively experienced. But objectively, we know that everything is physically happening within the brain and body. So if I can, through your medium, put forth to the population that we are not looking at anything called mental, everything is physical, and everything is actually reducing your lifespan and quality of life. And the population needs to understand that by treatment, you are actually going to avoid potential physical illnesses down the line, increase your lifespan, and who knows, the next person may be a CEO of a company with a bipolar mood disorder who lives longer and benefits the company and the community. So
I think this is a great point, because then at least this will put that little fear in people's minds to go get diagnosed and go get treated. And that's a great segue to my next question of what is the treatment?
That's a very critical question, because the biggest challenge we have is people may even come to the agreement of the fact that, okay, this is a brain disorder, like Ashutosh has so eloquently put forth, and we have been making all efforts to destigmatize it. But very often they get saddled with the diagnosis, but they're not willing to take treatment. Because there's so many myths and misnomers about what the treatment will imply. The biggest challenge we have is from within the medical community sometimes, where other doctors are very averse to our medications, say, नींद आएगी, brain dull हो जाएगा, weight बढ़ जाएगा. Some of those queries are, some of those doubts are justifiable. I'm not saying that that may not happen, but if you see, for that matter, there is no treatment in the world which is devoid of side effects. But if you look at the cost-benefit ratio, we are talking about longevity of life. We're talking about improvement in the quality of life. We're talking about the improvement in the quality of life, not only about the patient, but about the entire family at large.
Right.
Because this is amongst the most disruptive of psychiatric illnesses that we see in our day-to-day practices. With regards to the specific forms of treatment, you have to either treat the manic episode or the depressive episode with very specific drugs. They are very different drugs, and you cannot allow each of them to leach into the other area.
So it's almost like treating two separate conditions.
And that's the reason
And
why there
changing the
requires to be
treatment.
very, very regular monitoring. Because when a patient is in a manic episode, we have to use medications which control the manic symptoms. So you have to use benzodiazepines, you have to use antipsychotic drugs, all right? And these make the patient calmer, they take away all the behavioral problems, the agitation, the aggression. But if you continue those medications without any medical supervision, then it will eventually flip you over to the other side, where you'll start becoming more dull and drowsy and retarded than you need to. That's because you haven't followed up with the doctor regularly, and you've not given him the opportunity to fine-tune your prescription and maybe even take off some of the anti-manic drugs if you're out of the manic episode. As opposed to which, at the other end of the spectrum, if you are depressed, the vulnerability of suicide is a very big problem. So we have to ensure that the patient gets adequate treatment.
Right.
We may have to use antidepressants, but then we use antidepressants with the cover of a low potency antipsychotic, what we call as opposed drugs.
Correct.
So what that does is it reduces the probability of a switch again from depression to mania. The most important thing we need to bear in mind is the best treatment for bipolar disorder is to avoid future episodes, is not just to treat the current ones, for which the biggest help we have is from this group of drugs called mood stabilizers. Just the way you have voltage fluctuations in your home, if the voltage goes above a certain extent or below a certain extent, you will have all your instruments getting fried. So what would you do? You'd put a voltage stabilizer. You need to do the same thing for patients with bipolar. You want to give them a mood stabilizer. What mood stabilizers do is they don't allow the mood to elevate beyond a certain extent and neither dip below a certain extent. So you have to use mood stabilizers.
Isn't it a crutch for life? Isn't it better to, at the root cause, do things like, I don't know, alternative medicine or better lifestyle or meditation to not be addicted to these medicines for life? I mean, that's just one school of thought. I want to know your opinion.
Say, for example, if you're a diabetic, you may do as much yoga as you want to, you may meditate a lot, you may follow dietary practices, you may exercise. Is that going to be sufficient to treat your diabetes? Clearly not. If you have an insulin-dependent diabetes, if you are not going to take your insulin, you're going to die. right? So the same logic applies to psychiatric illnesses. You may have your reservations about psychiatric treatment, but even though some of them may have a certain degree of adverse effects, undesirable effects, the benefit far outweighs the risk or the potential side effects. So we have to ensure that you continue with your medications, not just to immediately mitigate the impact of your current episode, but to prevent future episodes. And we have a whole bunch of new medicines now at our disposal. Until a few decades back, we had very limited options, but now we have a whole bunch of mood stabilizers. We have lithium, we have sodium valproate, we have oxcarbamazepine, carbamazepine, lamotrigine, we have antipsychotics like quetiapine. These are a little technical for you, but it's a good point to make for many people who may have bipolar and they are listening to this episode.
Right, absolutely.
So these mood stabilizers eventually go a long way in preventing future episodes. So the most important treatment for bipolar is to prevent future episodes, which implies that preventive medicine is far more important than just the acute medicine.
Absolutely.
Because the moment people feel a little better, they feel, ab sab theek hai, ab dawai ki zarurat nahi hai, and they stop taking it. And that is reinforced by almost everybody around you all the time. Are you still on meds? You're better now. You seem to be okay. You're going to work. You don't need meds anymore. Ye ho jayega, wo ho jayega. But the unfortunate thing is, if they discontinue their meds, it's only a matter of time before they get their next episode.
Right.
And the biggest heartwarming feedback that we receive is from patients who have actually had multiple episodes in the past, and then they continue to struggle with the decision of taking meds or not taking medications. Eventually, they come around to accepting that the benefits far outweigh the risks. They continue with their medications. And we have patients now who have been episode free for decades and they're on treatment, and they are our PR agents for letting other patients know. So we conduct a lot of these group programs. We conduct a lot of these patient education activities where we invite patients to come and share their experiences. We invite other patients who are currently going through their episodes or they're unstable. We invite the family members, because no matter what a doctor might say, Ashutosh is an eloquent person to talk to. Maybe I may be able to convince them to an extent, but we are still outsiders. When another patient with bipolar disorder comes and tells you what they have gone through,
You can relate to them a
or
lot.
the relatives of bipolars, because that's another important point I'd like to highlight. The amount of caregiver burnout in bipolar disorder is humongous. So we see a lot of secondary patients. Just the other day, I had a patient who has a variant called rapid cycling bipolar disorder. What do you mean by rapid cycling is normally you have these episodes which occur once in 2-3 years. In rapid cycling, you have 4 or more episodes within a year.
Oof, very intense.
So they are practically flipping from the depressed to the manic to the depressed to the manic side. His wife of 27 years, all right, was at my clinic last week, literally crying out and saying, "Doctor, I can't take this anymore. I've actually contemplated leaving him because I can't take this anymore. It's too exhausting. It's just burnt me out completely."
Right.
So we had to actually encourage her to start speaking to our in-house counselor, give her a bit of supportive therapy, a little bit of awareness about the illness. After the number of years she's been dealing with this, she's learned a few tricks,
Right.
but it still is extremely overwhelming because this gentleman refused to take treatment and she would struggle and take him to multiple psychiatrists, and he continued to have episodes. He is burnt away half his fortune in his manic episodes, and then he has a depressive episode subsequently where he rues the amount of losses he has incurred on account of his illness. So it's a loop.
It's a
And
vicious
she's the
cycle,
one who's
yeah.
caught in that loop.
And that's a caregiver burden that you're talking
So
about.
we need to address the caregivers as much as we need to address the patients, because at the end
Also
of
to
the
treat
day,
the whole family.
you have to care for the carers,
Right.
right? That's the most important takeaway.
This is very intense. I think we've covered pretty much every aspect. So, Dr. Ashutosh, I want to come to you with, we've gone through everything. I think multiple facets of this condition. Is there anything that we might have missed out, not covered, that you just want to conclude the episode with?
So, few myths. A, the treatment involves medicine and medicine is the core. So, often I tell the patients that you can't have an icing without the sponge of the cake. So, the sponge is the medicine. The icing may be the lifestyle. And what we often try to tell the patient is lead a disciplined lifestyle. Do not have irregular sleep schedules. They can trigger episodes of bipolar mood disorders. Avoid substances because again they can trigger as much as possible. So it's not possible to avoid stress, but have and ask for help. And that may help you to reduce the stress because these are all the triggers.
Right.
Apart from this, there are certain myths that medicines do harm. So my answer to them is, in the hands of a nuclear scientist, nuclear power is safe. So similarly, in the hands of an educated psychiatrist, medicines are safe.
Right.
And lithium is the gold standard. It's the oldest and the gold standard. In fact, very recently, there's a publication also in lithium about lithium in Nature, saying that lithium deficiency is also getting implicated in Alzheimer's disease.
Okay.
So lithium is one thing.
Right.
The second thing is severe episodes of either mania or depression, which are not responding to treatment, necessitating hospitalization. Electroconvulsive therapy, the shock therapy as people know, given under general anesthesia is a lifesaver and a game changer. So there is no reason for them to not go in for this particular treatment. Again, in the hands of a trained psychiatrist, this is a truly lifesaver.
Right.
And third is a long-term treatment. So patients often say, how long? I say, how long do you want to live? Accordingly, we'll give you long treatment. So it is true that long-term medically supervised treatment will be a game
But
changer.
what about the side effects of a lot of these medicines that are long-term? Because I read an article in The Economist and a lot of publications about, yes, it is needed, but they do have massive side effects.
So I'm not saying no, but we are looking at side effects in two rubrics: dangerous, life-threatening side effects and manageable side effects.
Right.
The first, the dangerous, life-threatening side effects is a very, very thin slice. The manageable side effect, more often than not, is just a little bit of acidity or nausea, which we can always give under the cover of antacids or antiemetics. By and large, people tolerate these medicines, and again, in the hands of the expert, the side effects are not really a problem. The real issue comes that the patient perceives the need to take the medicine, because again, in treatment, we are looking at the acute phase, that means where they have a flare-up of either depression or mania, and the maintenance, that means where they are stable. Doctor, I'm fine. Why do I need the medicine? My answer to them is the other way around. You're fine because of the medicine.
Got it.
The medicine acts like a shield, preventing you from getting into a full-blown episode. And antidepressants given under the cover of mood stabilizer is the mainstay of your long-term treatment. So my only request is all those listening and who have bipolar or are supporting people with bipolar, please remove this thought from your head that medicines do harm. There is a lot of benefit of giving medicines, but under the expert supervision only.
My God, this has really been a mentally exhausting episode for me because just so many facets to this condition. But it's very important to know about this. And I think the good thing is we have two subject matter experts, two medical experts giving you a holistic view of the condition. And what can I say, 8 to 10 years to diagnose it. So that's 8 to 10 years of suffering that the person as well as their family is going through. Very critical that we understand this condition, we get educated, and we support people in our lives, people we may watch, as much as we can. Thank you very much.
Brilliant.
And
Thank you.